And we're going to wrap up our morning with Dr. Lipato still coming back and talking about sickle cell disease treatments. And we also hope that you've enjoyed our pets so far that we have ended our presentations with. These are pets of our staff that work with us both in our pediatric and our adult team. And we thought it would be a great way to kind of break up the monotony by showing our cute animals as we're going through our day. So hopefully you're enjoying that. Dr. Lipato, the floor is yours.
Hello again. So I will be giving an overview of sickle cell disease treatments, and I'm going to focus mostly on what we now call disease modifiers. So medications that change the way the sickle cell disease is actually impacting the body. First, I want to briefly just talk about blood transfusions. Dr. Sisler talked about this. Obviously, blood transfusions are an important part of sickle cell disease management. There are two kinds of blood transfusions: simple blood transfusion and red cell exchange transfusion. Indications for needing blood. Some of this has been mentioned. Having a pain crisis. Oftentimes we have patients coming in with a significant pain crisis, a reduction in their hemoglobin, and they'll actually get improvement with a blood transfusion. Acute chest syndrome, Dr. Sisler talked about that, is an indication as well. Strokes, obviously, and she mentioned requiring chronic transfusion therapy. We do have some patients who have symptomatic anemia. So we see this a lot in older patients who may have chronic kidney disease from sickle cell disease. So they have such a significant anemia that they really need recurrent blood transfusions to protect their kidneys from the anemia, to actually help with their fatigue. There are some other complications of sickle cell disease where you have a crisis involving the kidneys, involving the spleen, that require transfusions. Many times when women are pregnant, they may become significantly anemic during pregnancy. They may have a significant crisis that they will then get a blood transfusion. And as Dr. Sisler talked about stroke prevention, so just to prevent stroke number 2. Priapism is another indication where men with sickle cell disease will have a sustained and painful penile erection. Oftentimes that is treated with blood transfusions. And then ankle ulcers. We have many adults who develop these very painful ulcers around their ankles. And oftentimes the wound specialists will ask us to try to transfuse patients if they're significantly anemic to see if that will help with the wound healing. Now, there are complications with a lot of these blood transfusions. Dr. Sisler talked about some of this. Alloimmunization, delayed hemolytic transfusion reaction, and she did mention the iron overload. And I like, when I explain alloimmunization to my patients, not being a hematologist, I try to keep it very simple for myself. So, we understand the blood types. There's the ABO blood typing that most of us understand, that most patients are familiar with, whether you are A or B, ABO. And the way to think about that is just to think about the kind of hat that kind of sits on top of your red cell. And whenever you get blood, they'll do this testing to see what kind of blood is safe for you to receive based on the kind of ABO type that you have, the kind of hat that is sitting on your red cell. But that's not the end of the story. Hematologists and transfusion medicine physicians then get really into the weeds of what other kinds of proteins or other hats, other things on the outside of the red cell make my red cell different from someone else's. And it's not just simply the ABO. It's a lot of other molecules that make everyone's red blood cells slightly different than somebody else. And particularly with sickle cell disease, when patients get repeated blood transfusions, what happens is the body begins to become picky about what outside blood it wants to accept. And what I mean is, let's say I have red cells that have a pink hat, okay? And so I'm gonna accept blood that has a pink hat, perfect. But let's say there's something else about that blood that is slightly different from mine. I may have multiple transfusions with that kind of blood, but then at some point, my body says, you know what, I no longer want the kind of blood, even though it has a pink hat like me, but it has this other little thing, I no longer like that. So then what I'm gonna do is I'm gonna create like this antibody that's going to say, don't give me that anymore. And then when the transfusion medicine physicians have to find the right blood from the Red Cross, then they have to say, okay, now the body is saying, we don't want this particular thing. So now we have to be more picky. And then as you get older, you get more blood transfusions, your body just becomes pickier and pickier. It says, okay, I don't want it to have this little thing and that little bump there and that little divot there. All of those things I don't want. So I create all these antibodies, being more specific, pickier about what kind of blood I want to get. And so it makes it harder and harder for somebody with sickle cell disease to get the right match. Because as they progress in age, their bodies become pickier and pickier about what kind of blood donor they will accept. And if the pool of donors, the people donating blood, happen to be of a different ethnic group than the majority of the people that need the blood, which is true for sickle cell disease, the majority of the donors are white, and the majority of the recipients in sickle cell disease are of African descent, that alone means there's already going to be a difference. And so here you have patients who are already becoming picky about the kind of blood they're going to accept, and the pool of donors already happen to be of a different ethnic group, which will make that matching even harder. And so it really speaks to the importance of, and I put a plug in here, of people of color, African Americans, donating blood. Donating blood. Because individuals with sickle cell disease needs a pool of donors to be reflective of their ethnic background. And so that's one of the complications of these years of getting blood transfusions, is the body just becomes so picky about what it wants. And so then what happens is, if, say, I was totally fine getting blood that had a pink hat and this little divot, and then I change my mind. So I get that blood, and I mount a response. I get angry. I start creating all of these antibodies. I say, nope, don't give me that anymore. Well, the response isn't that bad, and probably nobody would even notice that I had that response. Okay, so they give it to me again, because they didn't know that. My body wasn't screaming loud enough. They want those antibodies on the blood to tell the Red Cross not to give it to me. But I said no, I created some antibodies for the first time, and now when I get the blood the second time, I have this bigger response. And this bigger response tends to happen days after my blood transfusion. So I'm in the hospital, I've gotten my blood transfusion, I go home, and then all of a sudden, days after, I have what's called a delayed hemolytic transfusion reaction, where my body starts to destroy the red blood cells that I've received. And so that's another complication of transfusions. And then, of course, as Dr. Sickle mentioned, iron overload is a very significant complication of repeated blood transfusions. And it affects many different organs. So, difference between simple and exchange. So, simple blood transfusion is just kind of what we typically think of. I'm in the hospital, in the clinic, I get a unit of blood. Exchange transfusion. So exchange transfusion is where if I have sickle cell disease and 95% of my hemoglobin is hemoglobin S, and I have a medical condition that really requires that rapid reduction in the hemoglobin S. For example, stroke. So I have a stroke, and the doctors want to rapidly decrease the number, that percentage. Then what an exchange transfusion is where they remove a certain amount of my blood. So by doing that, they're removing a whole bunch of hemoglobin S, and they're replacing it with blood that comes from somebody without sickle cell disease. So that is a exchange transfusion. And just to mention, obviously, biggest indication for exchange transfusion is when patients is when somebody has a stroke and they're being treated acutely for stroke. Oftentimes, as Dr. Sickle mentioned, it's done to prevent stroke number 2 from happening. Sometimes we would do exchange transfusions if somebody has had simple transfusions for so long, they have a buildup of their iron from iron overload, and now we want to do a kind of exchange where we aren't just simply adding more iron on top of the iron that they're already getting. Oftentimes, they'll switch to exchange transfusion. All right, so what are the medications? What are the disease-modifying medications? There are 4 disease-modifying medications in sickle cell disease. And my hope is that pretty soon there'll be more in the next couple of years. So hydroxyurea. Hydroxyurea, I think it was approved, FDA approved 1998 or 96 when Clinton was president. And what does it do? Well, don't worry about that big diagram. I'll kind of just tell you. Remember the kinds of hemoglobin. Hemoglobin A, A2, and then hemoglobin F. The kind of hemoglobin that we all had in our mother's womb. The kind of hemoglobin that we tend to all lose after we are born. Hydroxyurea is a medication that coaxes the body to begin producing hemoglobin F. Now, what's the benefit of producing hemoglobin F? Well, if we go and look at that dissociative curve again, so the top one is the curve that I showed you earlier, where you see hemoglobin A has a stronger ability to hold on to oxygen. It gets saturated with oxygen at a lower oxygen level. Sickle hemoglobin you need more oxygen to get that same saturation. Well, just look below. Look at how hemoglobin F compares to even hemoglobin A. So that curve moves to the left, which says that hemoglobin F, its ability to get saturated with oxygen is better than even normal hemoglobin. It requires less oxygen to saturate the hemoglobin. Its ability to carry oxygen is better. And so when that was discovered, that relationship, and I believe it was discovered by a female hematologist, probably in the 50s maybe, in New York, where she realized that the symptoms of sickle cell disease did not begin in these babies until that hemoglobin F dropped off. Then all of a sudden, you start seeing all of these symptoms in these young children. And that's when that connection was made, that there's something about the hemoglobin F that was protecting these young infants. And when they lost it, all the symptoms came. And then it took all that time to find a drug that actually induces hemoglobin F. It makes you produce hemoglobin F. And so this became the first disease-modifying medication for sickle cell disease. The other thing it does is that it reduces your white cells. Now, when I tell my patients that, and I do have to tell them that, I say that's a good thing, and that can be a bad thing. Because obviously you don't want to reduce your white cells so much so that you lose the ability to fight infections. But if you remember that other diagram that I showed you, where it talked about the stickiness of the cells, and I said that the sickle red cell sticks to the inside of the blood vessel, and I said that the red cell sticks to the white cells, and the white cells also stick to the inside of the blood vessel, and you have all this sticking going on. It is also thought that by reducing the white cells, that hydroxyurea's reduction of white cells also aids in that process of reducing all of that adhesion. So it's both the increase in in the hemoglobin F that is beneficial, but also the reduction in your white cells that is beneficial. But because of that, hydroxyurea isn't a drug that we give and send them out and give them a 1-year refill and don't see them again. We have to check their labs to make sure that we are not suppressing their white cells too much. And so it is a medication that requires follow-up, and its dose, the dose depends on the weight. Children, babies get lower doses. As they get older, they get higher doses. And that's probably one of the things that providers fail to do, is that we get patients on hydroxyurea. It was started when they were in the pediatric clinic. They come to the adult side, and we as providers, we just forget that this needs to be adjusted, that the dose needs to go up. Side effects of hydroxyurea, probably the most common side effect that we hear is GI upset. Headaches is another common one that I hear. And then hair falling out. And that can be a concerning one, because obviously nobody wants your hair to fall out. I tell patients that while you may have some hair falling out, and I'll talk about this a little bit, you're not gonna wake up one day after being on hydroxyurea for 3 days or a week and then look like me. You're still gonna have your hair. You might notice more hair on your brush. Many patients I have heard would tell me, I don't want hydroxyurea because it is a cancer drug. So why are you giving me a cancer drug? This is what I tell my patients. Yes, hydroxyurea has been used in cancer. There was a time when it was, I believe, used for leukemia. And yes, it is still used for a particular kind of cancer that results in the platelets being overproduced. However, the doses that we give for sickle cell disease are completely different than the doses that are given for cancer. And so I actively talk about this with my patients. I bring up all of the stuff that they may hear about hydroxyurea because I want them to hear it from me from the beginning, as opposed to getting on the medication and then a week later changing their mind and not wanting to take it because of what they've heard. The second disease-modifying medication, Indari, also called L-glutamine, I believe, I came to Richmond 2013, so I believe it was FDA approved maybe 2015. What is L-glutamine? Well, for one thing, it's a powder, as you can see. It's not a pill. And another thing is you can actually go to GNC and buy L-glutamine. You can get it over on Amazon. It is one of the amino acids that's in our body. It's actually one of the most common amino acids in our body. And the way L-glutamine works for sickle cell disease isn't well understood, but I'll tell you how I explain it to my patients. This is the nice chart that you find in all the textbooks that is attached to explaining L-glutamine. But this is how I explain it. In our daily process, just somebody without any disease, in our daily process, we produce toxins. We're constantly producing toxins. And the body has a built-in system where we remove toxins. We neutralize toxins. And L-glutamine is one of the most important amino acids that play a role in that cleanup crew that the body has. And we know that in people with sickle cell disease, the L-glutamine is low. We've known that for a long time. And so somebody came along and said, okay, since we know this, and since we know its role, what if we did a study and actually gave it to individuals with sickle cell disease? And it does show that it does decrease sickle cell crisis and can actually increase red cell life. But it is not fully understood how else it works. One of the barriers that we find in our clinic to patients taking it is the fact that it's a powder. And so, again, it is weight-based. And so you can see if I go back, you can see the size of that pack. And so for somebody my weight, I probably would have to consume probably 6 packs of those a day. So it's taking 3 packs, mixing it in the morning with something, anything, but not something hot like coffee or tea, but it can be in yogurt, consuming that, and then doing 3 more later on. So it's not as easy as taking a pill. So that's L-glutamine. The third disease-modifying medication was approved, I think this was 2019, which I can't remember which one came first, whether it was this one or the fourth one that came first, but they got approved, I want to say, a couple of weeks behind each other. Voxelotor. So voxelotor is a novel substance that, when consumed, it binds to the hemoglobin. So if you remember those 4 chairs that I had, the hemoglobin protein complex, it attaches itself to that complex. Okay? So what does it do? Well, it changes the way that hemoglobin complex holds on to oxygen. So if you go back and you look to the same dissociative curve that's on the right, where you clearly see hemoglobin A has a better capacity of carrying oxygen than sickle hemoglobin. We understand that. And then you look at the one to the left. And so the red curve is the normal hemoglobin. The red curve that you see is the same as the hemoglobin A that's on that other chart. So that's somebody without sickle cell disease. And then the blue curve is equivalent to the hemoglobin S curve that's in that other slide. When you take, or when somebody with sickle cell disease takes voxelotor, all of a sudden it changes that curve. It pushes that curve a little bit to the left. Kind of like what hemoglobin F does. Remember, hemoglobin F sits so far to the left, it's even better than hemoglobin A. So the voxelotor binds to the sickle hemoglobin. It doesn't change the structure. You're not switching out anything. You're not making it to make something new. You're simply binding to the hemoglobin, the sickle hemoglobin, and you're making that sickle hemoglobin actually begin to carry oxygen better. And what the study showed is that by changing the way the sickle hemoglobin carries the oxygen, if you remember, I mentioned it and Daniel Sopp mentioned it, that those hemoglobin molecules, they start to stick together and form a long polymer which deforms the red cell. That long polymer primarily occurs after the hemoglobin has been dropped off. And so because voxelotor changes how that hemoglobin holds on to oxygen, it in turn stops all of that polymer formation, which then in turn decreases the sickling, which then in turn decreases the rate of hemolysis, the rate of red cell destruction. And so the study showed that individuals who take voxelotor will actually have an increase in their hemoglobin. And so this is the third disease-modifying medication that we administer. Unlike hydroxyurea, which has this long history, we have a very full understanding of what the benefits are. And it's been tried in children, adults, African Americans, Africans, Indians, Brazilians, people from the Middle East. The newer agents, and this is what I tell my patients, because oftentimes they'll say, well, can I stop hydroxyurea? Is it better than hydroxyurea? I tell my patients, we don't know. We don't know if 20 years from now I can say the same thing about voxelotor as I say about hydroxyurea. And since I don't know, I will always use hydroxyurea as the #1 disease-modifying medication. If your sickle cell disease is bad enough that you need to be on a disease-modifying medication, my thought is, unless there is some really big reason why you should not be on hydroxyurea, you should be on hydroxyurea. then of course we can add other disease-modifying medication. But I mention that because that does come up a lot when patients say to me, I've heard about this new drug, can I take it instead of hydroxyurea? And then the last disease-modifying medication is crizanlizumab. And like I said, it approved 2019, really close by with Oxbryta or Voxelotor. So this is an infusion, it's not a drug, it's not a pill. It's an infusion, it's a monthly infusion that patients get. The first infusion, let's say if I got the first infusion today, my second infusion would be given to me 2 weeks later as a loading dose. But then every other infusion after that is 1 month apart. So what does it do? Well, that's that diagram I was talking about, which was talking about the adhesion. Here is the blood vessel, and you have the white cells connecting, sticking to the inside of that wall, and the red cells are sticking to the white cells. We know what is causing that sticking. And having graduated or did my training at University of Minnesota, I have some pride in that because the scientist, the physician that discovered that adhesion did the discovery at the University of Minnesota. And so we know exactly what is that protein that causes that sticking, the white cells sticking to the inside of the blood wall. And so crizanlizumab is a medication that blocks that sticking. It keeps the red cell, the white cells from sticking to the inside of the the blood vessel. And studies show that when you give patients this infusion, they will have decreased sickle cell crises, so sickle cell pain crises. And not only will they have a reduction in their pain crisis, but if they have a pain crisis this week, the next pain crisis gets pushed out. So if somebody typically gets one pain crisis every 2 months, the studies show that with this drug, they will start to have fewer and fewer pain crises. What has been our experience clinically with this drug? I think there's a growing appreciation that it takes several treatments to see some clinical change where patients will say, I now notice that I feel better. And the number that we are beginning to use at VCU is, let's see after you get 6 infusions under your belt, and we'll see, and then you tell me if you are beginning to notice an improvement. And so I tell that upfront to patients because I want them not to go there, get infusion number 1, they're in the hospital 2 weeks later, and then they say this medication doesn't work. Again, I'm trying to manage their expectations as we learn about the medication. And then the other thing is patients can have pain. And this is common with many different kinds of infusions, that they will have pain during the infusion process. And so we've had some patients describing having bone pain. And you can imagine that isn't a great selling point to tell somebody with sickle cell disease that I'm going to give you a medication that's going to cause you pain during the infusion. So we talk about that up front because I don't want them to find that out. And so when we give the medication in our infusion clinic at VCU, we make sure that the nurses have available to them pain medication that they can administer if that occurs. We've had patients who've had obviously itching or rashes from the infusion, and some of those, so far, we've been able to manage, again, treat either pre-medicating or treating during the infusion without having to say, well, you just can't, unfortunately, take the medication anymore. Now let's see if there's another slide I want to talk about. All right, this slide, no, we can skip this slide. Quick talk about cures. This is going to be a very surface conversation. I'm not a hematologist. So stem cell transplantation or bone marrow transplantation has obviously is a cure for sickle cell disease. I believe the first one was in 1984, and since then there have been, I can't remember what Dr. Smith had said, but well over several thousand, a couple of thousand bone marrow transfusions in the worldwide. So very simple bone marrow transfusion or transplantation explanation that I can understand is where you, well, first of all, there are kind of mainly three kinds of transplantations where you have what's called a matched related donor, a matched unrelated donor, and a haploidentical donor. In the body, all of our cells have, again, these little hats, and they're called human leukocyte antigens, HLA. So they'll do HLA typing, where, and they're, I want to say maybe 60, a lot of these little hats that distinguish my cells from your cells. And before you get any kind of bone marrow transplantation, you want your donor to ideally be a perfect match. And I think with sickle cell disease, they look particularly at 6 of these antigens. And if you are fully matched, so if I have a brother and he happens to be fully matched with those 6 HLA, that would be considered a matched related donor. But and also it has to be a brother, I believe, who him and I share the same mother and father. Okay. Because that plays a role in the matching. And then there is a unmatched. Now, the chances of me having that kind of a match, I believe, is about 25% chance that my full brother, same mother and father, or my full sister, same mother and father, the chances that we will be fully matched, I believe, is about 25%. And then you have a matched unrelated donor. So happens to be matched, but just not related to you. Well, how do you find that person? You go to centers where they use national databases of individuals who have donated their blood, and they have this database of all these different HLA matching, and you may find your full match in that pool, but obviously it's somebody who is not related to you. And then a haploidentical match is where you have a relative, usually your mother or father, and the matching is just half of the matching. And I believe that with that kind of bone marrow transplantation, it's obviously you have a better chance of getting that matching, but there's more risk of complication. So I believe that that's done really in the setting of research trials. But either way, what it involves is getting the donor, getting their stem cells, and purifying those stem cells so that you identify the ones that lead to red cells. And then you take that and you put it into the patient, into the donor, or the recipient. However, the recipient has to be primed to accept those cells. Because even if it is a matched donor, the body's not dumb. It knows that something not of me is coming inside me. And so oftentimes these patients have to have a significant amount of chemotherapy to then accept that, donated stem cell. And that process itself has complications. And no, I don't go into the complications, good, because that's above my pay grade. All right, the next cure is gene therapy. Sorry, gene editing. And that's been talked a lot about in the news, and the two scientists won the Nobel Prize for this. So, easy way that I describe gene editing or CRISPR to my patients is with this diagram. So if you remember the DNA structure and all those little spikes are these nucleotides, and each nucleotide dictates a message when you're creating that protein. In sickle cell disease, one of those nucleotides is flipped. And so because it's flipped, when you're producing that protein, you recruit another amino acid. You recruit a different one. So instead of recruiting glutamic acid, you recruit valine. And then that just changes the whole protein structure like we talked about. So now that we know that, these two brilliant scientists came along and said, okay, what if we created this enzyme? So an enzyme is something that likes to cut things. And so we said, okay, we want to cut the segment of the chromosome 11 because we know where that mutation is in sickle cell disease. We know exactly where it is. We've known about it since the 50s. Because we know where it is, we can create a cutting enzyme that we can put in the body, or in this case, put in the cells, and we can put in that enzyme an mRNA. And remember, the mRNA is a thing that reads the DNA. And we can design that mRNA so that it goes to the exact spot we want it to go in the DNA. And once the mRNA goes there, and it has our big old enzyme that loves to cut, it's then going to cut that exact segment that we want to delete. Well, that's not the end of the story, because the moment you cut the DNA is smart. It's going to want to fix itself. And unfortunately, it may fix itself in even a worse way. So they then have to quickly also have the right replacement, and then make sure that that right replacement, that correct replacement, the one that you now want to switch it to, gets put into that place. And then so that's what CRISPR is. Very simple way for me to understand it. And that's how I explain this to my patients. And so now you have this DNA that goes from having the classic sickle cell single mutation to now having what should lead to a normal hemoglobin. So that's one way CRISPR can be used in sickle cell disease. And so how do you then get that back into the human being? There's several ways. One kind of classic way is to do all of this in the lab, and then you have these cells that have now this edited gene, and then you engraft it back into the person with sickle cell disease. And if I'm correct, that engrafting process, again, the patient may still need some degree of chemotherapy to get that engrafted in. But there's another way that CRISPR can be used. And that's what's illustrated on the right. Remember I said that we all used to have hemoglobin F when we were in our mother's womb. And that's great to have if you have sickle cell disease. When we are born, almost all of us lose it. Well, we know why we lose it. There's a gene. There's a gene that creates a repressor It's a protein that stops you from producing all that hemoglobin F. So the body's just made that way. It's designed to make hemoglobin F when you're in your mother's womb. The moment you're born, that another part of the gene clicks on, creates a repressor, and all that hemoglobin F goes away. Well, we know that there's some people where that repressor gene doesn't quite work that effectively. And guess what? They still have a little bit of hemoglobin F just lying around. Not as much as they did before they were born, but it's there, 20%, right? Well, what if you go to that repressor gene and you use CRISPR to cut it out? So you cut out that repressor gene. So now I go from having a gene that actively tells my body, don't make F, don't make F, don't make F. Now I have a gene that doesn't say that. And now I begin to make hemoglobin F. So that is another way that CRISPR, gene editing, is being used to treat sickle cell disease, is remove the brakes from the hemoglobin F production and allow that hemoglobin F to begin to be produced. Because we know that hemoglobin F changes that curve and it improves the hemoglobin F. It improves the oxygen capacity. It's kind of like having a built-in hydroxyurea in your body without having to take hydroxyurea. You're just going to make a whole bunch of hemoglobin F. All right, I think that is all I have, and I need to show a video. And maybe somebody can come and show me how to turn it on, because they told me. Oh, they'll do it, okay.
Services plan to help biomedical services satisfy the needs of sickle cell patients. But before I share our plan with you, I'd like to share with you the reason I'm involved. A couple of weeks ago, my donor services executive said the words sickle cell at our regional leadership meeting. Whenever I hear the word sickle cell, whenever I read the words sickle cell, I think of my childhood friend. Robin, one of my first friends, battled sickle cell anemia. Robin was smart, caring, fun, and she liked a bit of adventure, which is a trait that I attribute to the antics of her older brothers. 5th grade was tough for Robin and all who loved her. That was the year that the disease prevented Robin from matriculating at our cherished elementary school. Robin was homebound, educated by the school nurse, so it appeared to me. I watched the nurse enter and exit Robin's home regularly. And on occasions, when I was allowed to visit Robin, she was in bed in the fetal position. Gone were her exuberance, her laughter, and her conversation. Robin outlived the prognosis of her doctor. She graduated from high school, graduated from college, had a successful career, married, and became a mom. Then, sickle cell took her life. In the Virginia region, we have a shortage of compatible blood units for transfusion to sickle cell patients. And the magnitude of our shortage ranks our region as one of the top 9 with greatest need of blood donation from people of African American ancestry. Thank you for your enthusiasm and eagerness to participate.
All right, so I think there was an issue with that audio. So it's time for some questions. And all right, let's see if I can, since the timeline for vaso-occlusive crisis are so variable and vary per individual, in a patient with known iron overload, at what point during hospitalization should be considered reasonable to consider transfusion for pain that is not responding well to opioids or other treatment modalities? That's a great question. So that's a good question. It's not an easy one to answer. I think a lot of it would be based on the patient's prior hospital course. Unfortunately, because patients are admitted frequently, we then get to learn what their typical hospital course is like. And we have a sense of what someone's typical sickle cell crisis is like. And we're able to then individualize their treatment. And I would say that so there isn't one answer for every patient, but it probably some of the factors would have to would be, is the hospital course, is the time frame getting longer than what is a typical crisis? One. Is the drop in hemoglobin from the baseline atypical? Is it worse than what we typically see with their sickle cell crisis? 2. 3 would be, are they beginning to show some signs of other organs being affected? So we begin to see a reduction in their kidney function, or we are beginning to see them needing more oxygen, or needing oxygen at all. So now we're getting concerned about, could this be acute chest syndrome? What I find is that the patients and maybe the non-sickle cell doctors in the hospital are more likely to want to transfuse early. And then we in the clinic are like, oh, no, please don't try not to transfuse them. But there really isn't a good answer. And sometimes it's not a right answer or wrong answer. But you really have to look at someone's past typical sickle cell crisis to decide, is this atypical? Is this worse than what we usually see? And then there's some times when it's just the length of time, when they've just been in the hospital for so long, and we just can't seem to break the pain cycle. And again, that becomes atypical of their sickle cell disease. So it's not anything to do with their hemoglobin or their kidney or their organs. It's just the length of time that they're in pain that we're trying to put in another intervention. So great question. It's something that comes up all the time when patients are admitted. Can you discuss the different types of hydroxyurea and which one would be ordered? Which one would be ordered over the other? So there aren't any different types of hydroxyurea. There are different. So there are pills. There's liquid. There may be. You may see hydroxyurea that has a different brand name, but from a clinical standpoint, the big difference is the dose of hydroxyurea. So I hope I'm answering what that question is getting at. There aren't different classes of hydroxyurea. There are different doses, and that is determined by your weight. There are different formulations of the drug, whether it's a pill, a tablet, a capsule, a solution. That a lot of that is just kind of like what your insurance will cover. We tend not to use solution in adults, but sometimes patients will require a solution, and that may be why we would use that. Is there any benefit in sickle cell disease from taking over-the-counter form of L-glutamine, perfect, versus prescription? So when L-glutamine came out as a prescription medication, we had a hard time getting it approved by individuals' insurance companies. And so yes, we would tell patients to take L-glutamine over the counter. What's the concern? What's the problem? Well, one is, and I've looked into this, we want to, as much as possible, try to match the over-counter dosing with the dosing that we know has been shown to work. So if, based on my weight, I need 30 grams of L-glutamine, then I need to find a big powder of L-glutamine that I can reasonably take to achieve 30 grams. They sell L-glutamine as a powder, but it's also sold as a capsule. And the capsules can be as small as 100 milligrams, 200 milligrams. So if you're trying to get 3 grams, or maybe, sorry, if you're trying to get 30 grams of that, well, you can't. You're consuming so many capsules. So we have to kind of research what's out there, and it always becomes a powder that the scoop, one scoop, is close enough to 5 grams. Use this about 3 grams. So you can get them pretty close. Yes, I have found patients say that it is effective, it helps. The problem is, another problem is, it is not pharmaceutical grade. So the makers are not regulated by the FDA. And I can't say for sure that that 1 teaspoon or that 1 scoop really is 5 grams. With something that's pharmaceutical grade, FDA approved, then our assumption is that yes, that should be 5 grams, or else you're going to be getting in trouble with the FDA. But the answer is yes. We do have patients take it over the counter. What are recommendations to reduce side effects from taking these modifiers? Yeah, wonderful. So let's talk about, so I probably didn't mention, so voxelotor, biggest side effect, GI upset. That is probably a common one, more so than hydroxyurea. It can be cramping pain, nausea, and I've also heard diarrhea. So for voxelotor, and also for hydroxyurea when it comes to the GI issues, dose reduction is probably the more common thing that we try to do. With hydroxyurea, obviously, I can just look at your weight and say, based on your weight, this is how much hydroxyurea you should be on, like your max, okay? And oftentimes we don't get to that max. We might reach, if your max is taking 5 pills a day, we might get to 3 pills a day. And you might say, when I was at 5 pills a day, that was too much. I had GI symptoms. So I would say, okay, stick at 3 pills a day. What I've learned and what I try to tell my patients is, I would rather you take 3 pills a day of hydroxyurea every single day for the rest of your life than you maybe take 5 pills once a week, because that adherence is so important. With voxelotor, with the studies, everybody took 1,500 milligrams. Everybody took 3 pills. There was some evidence that 2 pills, I believe, did the trick, but the studies show that 3 pills is it. So what we tend to do is, if somebody has symptoms, I would say, let's try to gradually get you on the voxelotor. So we start at 1 pill. And then if you tolerate that, or if you have GI symptoms, many times those GI symptoms will resolve after a month or 2. Then we begin to slowly increase. And then, of course, you can use other medications dicyclomine to treat the cramping, anti-diarrhea medications to treat the diarrhea. But I guess I try to pick a low dose that they can tolerate and then slowly increase as the way to mitigate side effects, as opposed to adding something else on to try to treat the side effects. But that has also been done successfully. All right, last question. Oh goodness, what are the complications that may occur during a bone marrow transplantation? All right, I read about this today, yay. Okay, so infection, big risk, is the process of going through the chemotherapy is infection. That's one big complication. And then graft versus host disease, where the cells that are being engrafted, that are being given to the individual, start to recognize that I am not in the right body. And so you then have this overwhelming immune response that can make people sick. The last time I took care of that was in med school, so I don't remember all the details. But the worst complication is graft failure, where you no longer get that response. So the cells that have been donated and have been received are no longer doing what they were intended to do. And that occurs in sickle cell disease, but also with different kinds of cancers where transplantation is used. All right. I think we're finished. All right, thank you very much. That's the end of my talk. Appreciate it. Thank you.
So, well, I think Dr. Smith wants to step on in before we break for lunch. Hold that thought.
Me again. We found a slide omission, and that was the omission of the discussion of one of the gene therapies types, and that's called gene addition, ADDITION, not EDITION. And that's where you take a virus, usually a lentivirus. The lentivirus is actually the type of virus that causes HIV, Shirley. So this is the 60 Minutes broadcast that got the world bent out of shape that we were giving HIV to sickle cell patients.
I remember.
You remember that?
I do.
We are not. We have emptied that virus of all the goodies. There's nothing in there that will give you HIV. But the envelope of the virus is used to add the gene for fetal hemoglobin back to your cells. Then they introduce those cells, your own cells, back into you. Just like CRISPR, except now you're adding, not switching. And that's actually the more common of the gene therapies that are currently being used. And I think there's something like 30 people that have had it done. And if you've been keeping up with the news, that's the trial that got stopped when we discovered cancer in a few patients.
Yes, I remember that too.
And the trial has been restarted. And at this point, we can't blame any of the things that are in the virus or in the gene addition for causing the cancer. So we started the trials back up, and we're doing more research. So I thought I'd add that to those who are listening. You've got gene addition, and you heard the kinds of gene addition going on in addition to bone marrow transplant.
Thank you, Dr. Smith. Yes, we were having a sidebar conversation about that while Dr. Lipato was presenting, and we found that was something we really wanted to share with you today because it's just as equally significant as the other two trials that he brought up. So I know we gave you a lot of information. A lot of great medical information was shared this morning. We hope you found that that was really beneficial. We are going to break for lunch, but when we come back, we're going to turn the tables a little bit. And although this is also going to be a heavy conversation, we thought it is one that is very important to share in this conference. We've done it before. We've now felt the need to bring in some additional experts in this field. And we are going to really focus on health disparities, the impact of science on health disparities and racial stigma and bias. And we have 3 different presenters that are going to help bring that all to a package that we feel is really going to provide a lot of insight to everyone. We all know that patients with sickle cell disease do feel stigmatized, and they do feel that their treatment is altered many times just because of how they present themselves to physicians and physicians' lack of knowledge or insight into the disease. So we're going to break for lunch until 1 o'clock. We do have some music tunes if you're going to sit at your desk or wherever you're at that you can listen to. And we hope you join us back at 1 o'clock for this wonderful presentation that we're going to be having at that time. Thank you all very much.